me introduce Dr. Nelly. Dr. Nelly Pato. She's a medical, she's the MOH, Makadar, sub-county, Nairobi. I met her when she was one of our students at Liverpool. She did her master's at Liverpool School of Technical Medicine, where Charles teaches. And she's one of our products. And her project, her MSc project, she used our data in the secretariat to come up with a research paper. So, congratulations.
Thank you. Thank you so much. Thank you so much. Dr. Pamela, for that introduction. I don't need to introduce myself again. I think that was sufficient. So I'm going to present to you. Sorry, I do not in a COVID. So I did a study of the risk factors for maternal mortality among women who had cesarean delivery in Kenya, and this was a study that was based on whose data was taken from the first CMP that my colleague has just presented. And we were able to publish it in the East African Medical Journal. And my co-authors were Dr. Pamela, Dr. Helen Alot, and Professor Charles Hami, who was my supervisor while I was doing my dissertation in LSTM during my MSc studies. So if you want to have a look, maybe more details about the paper, because of the detail, you can go ahead and check it out with the East African Medical Journal. So, what was the background of this study? We see that Kenya is amongst the top countries that have been ranked to have a very high maternal mortality rate in sub-Saharan Africa. This was according to the WHO report of 2015, and I don't think it has changed much over time. And the MMR at that time, in the year 2015, was 710 deaths per 10,000 live births, which is quite high, compared to the target that was given in the SDG 3 of 140 deaths per 1,000 live births. Then again, we're going to say that for us to be able to lower the maternal mortality, cesarean section is a very important procedure, surgical procedure. We think it's life-saving. If a mother has developed complications and there are indications to have the cesarean section done, then once we do it, we're able to save a mother's life. So cesarean section has really come in handy to be able to save quite a number of maternal lives. But however, we see that over time, there's been a debate of whether cesarean section actually improves or the rate. The higher the rate, because now we're saying it is life-saving procedure, right? So now we ask ourselves, if we have very high or quite high rate of cesarean section rate, then does it mean that we are going to save more mothers and hence have lower maternal mortality rates? But we see that over time, it's been a debate that has been ongoing, and it's actually been proven that it's not linear. The relationship between the CS rate and the maternal mortality rate is not linear. So it does not mean that if we have a rate of maybe 20%, then our maternal mortality rate will be less. And then we see that maternal mortality rate and morbidity is still high, as I'm explaining, even with the CSS that are going on. And also it has got quite a number of complications. So it's a surgical procedure. So we are also seeing that we are having a higher prevalence of mortality and morbidity amongst those who are undergoing cesarean section compared to those that are having vaginal births. And here is a picture globally where we are also seeing that an increase in maternal, not maternal, but cesarean section rates does not immediately or automatically translate to lower maternal mortalities. And you can see on the far, this is to you, it is your right, on that graph on the right, it's showing different CS rates in different countries. You can see Bangladesh quite up there, over 60%. Myanmar is there, Pakistan, there's Egypt. Then when you go down amongst those countries that have quite a bit lower rates of cesarean section, that is South Sudan, the Gambia, and Burkina Faso. But we are seeing that when you compare these ones in the different countries, you can see all the rates are really quite high, and it cannot be compared with the CS rate that was recommended of 10% by WHO in the year 2013. Actually, the recommendation was 10 to 15%. Most countries are actually, if you look even at that graph,
are way above the 10 to 15%, but still that does not translate to lower maternal mortality rates. The graph down there is the Kenya CS rate trend between 2014 and 2017. You can see even in Kenya the picture is not any different. The cesarean section rates have been going up from the year 2014 to 2017, but still when you look at our maternal mortality rate, it does not translate to lowering of the same. So there's that Robson 10 group classification that was developed and an implementation manual was actually published in the year 2017. So this is a tool that was proposed, or a tool that was developed so that we can be able to assess, monitor, and also compare CS rates within a facility or different or within settings that are more or less the same, and it focuses mostly on the obstetric factors, that including the parity of the woman, the gestational age, also the presentation and the lie of the baby or the fetus, and also the number of fetuses. So this has been helpful to see whether to compare whether those CS rates are actually translating to an improvement or not. So the rationale of the study, first of all, we have already mentioned that we based our data on the first CMD. So from this report, 37% of pregnant women who died during that time had actually had cesarean sections done, which translates, that was 138 women. So then our question was, this is a life-saving procedure. Why would a woman go through a cesarean section and still end up dying? So we wanted to look further and see, do these women have different, specific characteristics that predispose them to dying even after having the cesarean section done. So we wanted to determine the risk factors that were associated with mortality, and this would facilitate in us developing context-specific actions to reduce the risk of maternal death. Because if I know, for example, that maybe parity is a risk factor, then when I have a woman who is multiparous, then I would be on the lookout and give more care or quality care or follow up more closely so that that woman does not end up dying. So that's why we went ahead and did this study. So we had 3 objectives. The first one was, first of all, to determine what the risk factors were based on the population that we had. That was the women that died after having cesarean section in the year 2014. And then we also wanted to assess whether it's feasible to apply the RTGC in Kenya, and then also develop recommendations for us to be able to improve the quality of care. That diagram simply shows the Robson 10 group classification. It's quite small, so maybe I'll just try to explain it. So right at the center is the Robson 10 group classification that bases on obstetric and clinical factors, but we know that obstetric and clinical factors are not the only risk factors that predispose a woman to mortality or morbidity. So the obstetric and clinical factors are surrounded by community factors, they are surrounded by healthcare provider factors, they are surrounded by the women themselves, their characteristics, all those factors. So that's why there is that big circle as we keep going out from the core of the circle. So we used the case control study. So we had cases, those are the women that had actually died, which was 138. And then we had controls. Those are women who delivered in the same year, in the very same facilities where the maternal deaths occurred. So that now we are able to compare. These women have different characteristics that were in the ones who died. They have some characteristics or risk factors that these women who were able to survive after the cesarean section in the same year, miss or not have. So we had, so after doing quite a bit of cleaning up of the data, we had ended up with 126 women as cases. Those are the ones who actually, the ones who died. So we were using case notes of these maternal deaths. And then the controls, we used a 1:2 ratio. So we had 252 women who actually survived after having cesarean section in the same year. And then we used multiple regression analysis using the SPSS software. And we came up with adjusted odds ratio with a
factor of 0.05 for us to be able to determine the risk factors. And we also checked for completeness of data so that we could be able to apply the ACT-GCS to both cases and compare them to the control. So these are our results. Postpartum hemorrhage was one of the risk factors that was identified after we went through a very thorough process of data analysis. We had a parsimonious model that gave us the following risk factors. So postpartum hemorrhage was the number one there with the odds ratio of 27.5. The confidential interval is stated on the table. Then the other risk factor that was identified from the study was blood transfusion. So if a woman went through blood transfusion, they had the odds of mortality at 14.5. And another one was referral to ICU. So if a woman went through care and at the study identified that they had a risk of mortality at the odds of 27.5 with that confidence interval. And then the use of general anesthesia was another factor that we identified. And this was done after we had controlled for several confounders. So going forward, 45% of the women in our sample were having their first-term baby following spontaneous onset of labor. This is class 1 according to the ACT-GCS classification, and 33% had a previous scar, which categorized these women into category 5 of the Robson 10 group classification, and then less than 10%, that is 24, had missing data in the control group to classify the births using the ACT-GCS classification. So going back to the risk factors that we identified, we see that most of these risk factors are modifiable and they are related. Because we have talked about postpartum hemorrhage, we've talked about blood transfusion, we've talked about ICU care, we've talked about the use of general anesthesia, and the other one was, the other one also was having gone to ICU care. So you can see all the factors are quite related and they are modifiable. So these are factors that can actually be mitigated. When you look at PPH, for example, it's the leading cause of maternal death, right? And yes, actually, if you can rank those risk factors, maybe the highest, factor with the highest risk factor there. So you can see this PPH can actually be prevented, right? And it can be modified. And you can have, we can think about things like NC visits where we can be able to pick women who are anemic in good time and intervene in good time, and all those other factors. Blood transfusion, by the time we are transfusing a mother, it means that their HB is quite low, right? And they are quite anemic and they have lost quite a bit of blood. So you can see all these factors are just quite related. And we can actually, there are things we can put in measures, we can put into place to be able to mitigate them. So these are the recommendations that we came up with. First of all, we need to identify the women that are at risk early, meaning that ANC is very important. So we need to really encourage these mothers to come for ANC visits quite early. One of the things that we have observed over time is that most women wait for third trimester to come for ANC visits. And so some of these risk factors cannot be identified. But if they can be identified early, then we can put up measures, we can treat the things that we are going to see as red flags and be able to prevent PPH. Use of regional anesthesia where possible, because we can see that general anesthesia use was one of the risk factors that we identified in the study.